welcome to the coffee table. I'm your friendly host, Mina Malik Hussain, and as usual, we have a wonderful show lined up for you today. You know that we love to do arts and culture on the show, but we also like to talk a lot about medical issues because we think that spreading awareness is such a crucial thing, and especially with diseases that are still pretty common in this part of the world. And so we feel like having certain conversations and coming at them from different angles is always such a useful and important thing to keep doing, to keep at it. And you know, of course, every year the conversation changes, awareness levels differ, medical expertise differs, and you know, this show is no different. I'm sure, as you are all aware, the 8th of May is World Thalassemia Day, which means that the 8th of May is a day that's set aside for people around the world to educate themselves about thalassemia. What is the disease? What does it mean to have thalassemia? If you have a diagnosis, how do you manage your symptoms? How do you manage the disease? How do you get thalassemia in the first place? It's quite straightforward, and it is also preventable, but it's also, as many things are, quite a complex conversation. And we are so happy that we have two wonderful experts on the show to help unpack all of those issues for us today. We are being joined from Islamabad by Dr. M.Ayaz, who is the clinical chief of the bone marrow transplant unit at Shifa International Hospital in Islamabad. He served as a fellow in hematology at the State University of New York and Buffalo. He holds a fellowship in bone marrow transplant from the prestigious Mayo Clinic in Massachusetts and is a diplomate of the American Board of Hematology and Internal Medicine. And also joining us today is Major General retired Dr. Tariq Satti, who is a consultant hematologist and bone marrow transplant specialist at Shifa International. He trained at St. George's Hospital in London. He is a pioneer in the field of haploidentical bone marrow transplants in Pakistan and has the honor of being a recipient of the M.Ayaz in 2018 for his services to medicine and the state. We are so happy to have both of you on the show today. Welcome, doctors. So, Dr. Ayaz, I like to, as I always say on this show, begin at the beginning. So, when we say thalassemia, what kind of disease are we talking about?
So, thalassemia is a blood disorder which is congenital, but that we mean it is there by birth. It is not acquired usually. And unfortunately, in this part of the world, in Southeast Asia, it is still very prevalent. It used to also be prevalent in Mediterranean, in the Greece, Italy region, where it has almost been eliminated. But in this region, it's still there. In thalassemia, the basic defect is in the bone marrow stem cells or seeds that produce blood. There's a protein in blood called hemoglobin that actually makes our blood red. And that protein is defective. The usual life of that protein in a normal person is 4 months. But these kids, the protein they make is of substandard quality, and it lasts them maybe a month or less. So the issue is with the quality and quantity eventually of the protein hemoglobin they produce in their red blood cells that carry oxygen.
So what happens when your hemoglobin breaks down that quickly?
These children, when they're born, they have some of the hemoglobin they have borrowed over from their fetal period, from the mother's womb. And eventually in a few months, 4-6 months, that starts to expire. It's called fetal hemoglobin. And then these kids, you suddenly find out that the baby that is 6 months old, now his hemoglobin is 8, which normally in children should be like 14, 15 or more. And that prompts a blood transfusion. So this is highly unusual. No child at 6 months of age should require a blood transfusion, and that should always raise a red flag as to what the cause of this is.
Quite right. So I'm trying to understand that usually hemoglobin is supposed to sort of be viable for up to 4 months, and then what is the normal cycle of this? So for a layperson to understand that basically your blood kind of renews itself every 4 months, and then in thalassemics, that renewal process either needs to happen more often and also doesn't happen correctly.
Both of these are true. So actually when your life cycle is that is supposed to be 4 months for the red blood cells that keeps expiring in a month or 3 weeks or 2 weeks, two things happen. One, the body goes into overdrive. The body tries to compensate for that. So it tries to produce hemoglobin in regions where normally it is not produced, like liver, in the skull table we call. And the other thing is the system tires out. The system that is supposed to be renewing a thing every 4 months. It's like, if you were to do the cleaning of your house like once a week, and they make Allah know you have to do it every single day. That is tiring. That is a lot of work. So same two things happen to the body. It goes into overdrive and it gets tired of doing what it is supposed to do at a certain interval.
Absolutely. And I want to kind of come back to the physiological effects on the body, because I know that I can name at least two from my notes. But I want to kind of sort of still keep digging into thalassemia generally a little bit. Major General retired Dr. Tariq, can you hear me?
Yeah, I'm hearing you.
Excellent. Achha, Dr. Saab, so can you sort of tell me, from what I understand, that there are, in our blood, there are two kinds of thalassemia, basically. So tell me what they are.
The thalassemia is basically, as already been Dr. Ayaz discussed together, it's basically a defect of the hemoglobin. And there are two types of hemoglobin defects. One is that the qualitative defects, like in which there is a group of conditions, they are called structural hemoglobin defects. And the second is there's a quantity is less produced. They are called quantitative defects, and in that there are two types of hemoglobin disease. One is beta thalassemia and the other is alpha thalassemia. And as you know that in our body, the hemoglobin is in structure is basically alpha chains and beta chains. If the defect is of the alpha chains, that is called alpha thalassemia, which is not very common in this part of the world, although the carrier rate is around about 8%. And the second is then, of course, is the beta thalassemia, which is very prevalent in this part of the world, into Pakistan. And in the Pakistan at the moment, there are about 80,000 cases of thalassemia major. And the thalassemia trait, that is thalassemia minor, are around 5% of our whole population of the Pakistan is suffering from thalassemia trait. So these are basically the two types of defects of hemoglobin in this part of the world.
No, I'm glad that you brought up how many people have thalassemia in Pakistan. So, Dr. Saab, we briefly talked about how thalassemia is an inherited disorder. You can't catch it, or you can't sort of contract it from an infection, for example. So why do you think that thalassemia rates are so high in South Asian countries, for example, and also as they used to be in Greek or Italian cultures? Like, I know the answer, but I want you to tell me.
Yeah, actually what happens is that, as you know, that the intermarriages is very common in this part of the world, especially in Pakistan, India. So basically this disease has been transmitted through Mediterranean belt by the Roman Empire. They came here to this part of the world. And then they transmitted along the Mediterranean belt. And especially nowadays, at the moment, the disease is more prevalent in Indo-Pakistan, Bangladesh, Middle East countries, and it's almost finished in the other countries like Cyprus and Italy and Greece, which were actually the pioneer of this disease. So the transmission in this Pakistan, if you can ask me, it's basically the family marriages, which is very common in this part. And one of the study which was done in Pakistan have shown that there are about 50 or 40 families or the races or the tribes which have actually been the source of this thalassemia. And then the marriages which are going on. And then they are transmitting the disease to other people also.
Absolutely. I will sort of talk a little bit more about consanguinity in just a moment. But sort of back to the disease. Dr. Ayaz, what are the symptoms of thalassemia? Like you mentioned that infants start displaying signs of what is commonly seen as anemia. So I think what I'm curious is that how does thalassemia display when you have it?
It changes with the age. The way thalassemia or anemia manifests itself. Thalassemia basically causes anemia, which is deficiency of hemoglobin, and it depends on the age of the child. For example, in a very small infant that is breastfeeding, we call it poor suckle. the child gets short of breath, just trying to get his feed. And then when they grow up a little, you see that when they're trying to crawl or walk, it's tough for them. They're weak than a normal child. And also it'll affect the growth eventually, because the oxygen to growing tissues and bones, muscles, brain is not as it should be. So in children who are poorly managed, we have children that come to us from Balochistan and other remote areas who have not been adequately transfused. And the first thing when they enter in the clinic, you notice is they are short in height, and they're malnourished and they're underweight. So growth, fatigue, and shortness of breath, and with increasing transfusion, then they run into two other major problems, which I'm sure we'll talk about.
Yes, yes, we will. But Dr. Saab, do you feel like the prevalence of thalassemia is still so high, partly because how thalassemia manifests, people mistake it for ordinary anemia? Do you think that there's a lot of misdiagnosis as well?
That is true, especially for thalassemia minor, which is a type of thalassemia. So beta thalassemia, there's major and minor. There's two genes that control the synthesis of hemoglobin. In major, both are defective. In minor, one is defective. Minor is actually very prevalent, more than 5% of Pakistani population. And these people I see all the time, adults, children, women, their hemoglobin typically runs around 10, 11. And people see them, even physicians see them, and they start prescribing iron, which is not a right thing to do. So yes, it is the diagnosis is delayed. In children, even thalassemia major, the diagnosis is delayed for years sometimes, especially in remote areas. So delayed diagnosis is a problem with thalassemia.
No, I just sort of, when I think about these things, it gives me pause for a moment. But Major General Tariq, what's the difference between thalassemia major and thalassemia minor? Dr. Ayaz touched briefly on it, but could you sort of explain it in a little more detail?
Yeah, the one thing is they're very simple, that as Dr. Ayaz also told you, that in thalassemia minor, most of the people are just normal, and they are picked up when, especially in the females, during pregnancy, because of that, they develop iron deficiency also, and the more iron blood requirement, so they become slightly anemic. Otherwise, they are just silent carriers. Whereas thalassemia major is on the other side. They usually have becomes transfusion dependent or becomes very anemic by the age of 1 year, and so on and so forth. So these are basically the difference. Second is, if you ask from the technical point of view, what is the defect in the alpha and beta thalassemia, sorry, minor and major. In the minor thalassemia, as you know, that there are two genes in each of our RBC. If one gene or one alpha beta gene is defective and the other gene is normal, these are called the carrier or thalassemia minor. Whereas if both the alpha beta genes become defective, they are called beta thalassemia major. And nowadays there is another term also used, that is called thalassemia intermedia. And the intermedia are those patients in which the molecular structure is quite similar to that of beta thalassemia major, but they are usually not very transfusion dependent.
Oh, okay. So there does seem to be a slight spectrum for thalassemia as well. That's very interesting. So just to kind of break it down, basically everybody has two pairs of genes for various things. You get one gene from your mother, you get one gene from your father. So if you get two thalassemia genes from your mother and your father, you have thalassemia major. If you get one from one parent, then that is minor. And then there's also an intermedia where you might have got it, but the intensity of the disease is not as strong. Correct? Have I sort of got that right?
Yeah, very right. It's like this.
Yes. Excellent. I like it when I get my medical science right. We're going to take a very quick break and come back to this really interesting conversation. Stay with us. Welcome back to the coffee table. We're having a riveting conversation about thalassemia and blood issues with consultant hematologist Dr. M.Ayaz and Major General retired Dr. Tariq Mahmood Satti over Zoom, because we are responsible here on the coffee table. So, Dr. M.Ayaz, we've talked about symptoms and we've talked about general carrying thalassemia. So, what does it mean to be a carrier of thalassemia? So you don't really manifest any symptoms of it, you don't require treatment, but you have like this silent, dangerous gene just sitting in your cells. And do you think that a lot of times people are not aware of the fact that they are carriers?
That is a very good question, because there's three things I tell my patients with thalassemia minor. One is the anxiety factor. I tell them that this is incurable. You don't need to fix it. The only way to fix it is a bone marrow transplant, and it's not worth it, because most people with thalassemia minor will have a normal lifestyle. Their hemoglobin, sometimes they're only accidentally discovered. They do blood for another reason, and they find out they're slightly anemic with a hemoglobin of 10, 11, 9 sometimes. So one thing they need to know is that this is a defect that is there, it's mild, it cannot be fixed.
Right.
The other thing they need to know, as I alluded before, is that they automatically, people assume because they're anemic, they put them on iron. Yes. Unless they are really iron deficient, they should not be given iron supplementation, because that deposits in their liver. It's actually detrimental. And the third and the most important thing is their genetic counseling. Like you said before, because if you have thalassemia minor, that means you have one defective gene. So if you marry another person who is thalassemia minor, there's a chance that both of you will inherit a child that has thalassemia major. So marriage counseling, in Punjab actually they have a law at this point, which I don't know if many people comply with, but you're required genetic screening. If you have thalassemia in your family, you have thalassemia minor, it's not a problem for you. But you marry a cousin or a person who's also thalassemia minor, then a quarter of your children, 1 in 4, may have thalassemia major, which you need to be aware of. It's not necessarily, we don't tell you who to marry, but our job is to tell them the hazards of doing this.
Absolutely, but Dr. M.Ayaz, a 1 in 4 chance is a very high risk. And given that on average people in this part of the world do have at least 2 to 3 children in most families, 1 in 4, isn't that a very high risk?
Average family size in Pakistan is 6.
Wow, I was being sort of conservative with my estimate, but if you are on average having 6 children, and if you are a carrier, then that means statistically 1 of your children will have thalassemia major or even minor.
So when I say family size, that includes the 2 parents. So 4 children, yes, one of them is going to be very likely to have thalassemia major. And if that happens, then your options, there is now genetic screening, actually very good data from one of our colleagues, General Suhaib, that you can tell in mother's womb that this child that she's pregnant with has thalassemia major. And then there's this whole ethical religious debate. People have issued fatwas about should you abort that child or should you let that child come into this world, and can be very stressful. There's families, I know families where they're taking care of 2 or 3 children with thalassemia major, and then a 4th one is born. So everything is exponentially, the stakes, the caregiving, the burden on the parents, the family, the system is quadrupled. So it's better, wiser to prevent this with genetic counseling. And if a thalassemia minor marries a normal person, the chances of their children getting thalassemia major is 0. So they can marry.
But is there a chance that they could be a carrier? There is a chance.
There's a chance they could be an asymptomatic carrier. But if you screen people before marriage, like the law says, at least in Punjab, the chances of this happening are very, very minute.
Which is really, really good, because if one were to kind of consciously keep doing this, then eventually, I suppose that means that one could kind of eliminate the disease or really be able to control it. Because I do know that in Sicily, for example, or in Cyprus, like Dr. Tariq mentioned, they've been able to kind of almost completely control or completely eradicate thalassemia from those regions through genetic screening and through making sort of informed decisions when marrying and having children. But that, sadly, it's, again, I think that, and this is something that we can talk about, is that it's much more challenging in developing countries to do this. But before we talk about that, Major General retired Dr. Tariq, what are the treatments for thalassemia? So if you have thalassemia major, like proper full-blown thalassemia, how do we go about treating that?
The treatment of thalassemia major is a very, very laborious exercise. And it has got different treatment modalities. But initially, what is required is that you follow the patient child and to keep the hemoglobin above 10 grams hemoglobin, because if the hemoglobin remains below 10, then the chances of the complications like iron overload, the short stature of the patient, the facial deformities, and liver enlargement, spleen enlargement, and the other complications which occur with the passage of time. So the most important thing is that you monitor the patient initially. If the hemoglobin drops, say about less than 8 grams, then start transfusion. And the program which is called is hypertransfusion program, in which you keep the hemoglobin above 10 grams. And whenever the hemoglobin drops below 10, then you have to transfuse the patient. The second important thing is you monitor the serum ferritin level, that is the stored iron in your body. If it drops, if starts increasing, or if the patient transfuse more than, say, about 10 to 15 liters of blood in his life, so you have to start the iron chelation therapy also.
Yes, absolutely. Tell me more about chelation. Why is iron chelation important, and what is it?
Yeah, actually, as you know, that the iron overload is very, very dangerous to the body. And the stores of our body are the liver, spleen, and when it becomes overloaded with the iron, they start storing in the endocrine system of our body and to the heart. And so the complications of this iron overload is the liver failure, the cardiac failure, and the endocrine deformities like the non-development of the genital organs and diabetes mellitus and so on and so forth. So these all problems can be solved if you start iron chelation therapy as early as possible. And the iron chelation therapy that still is the gold standard is desferrioxamine, which is actually is a subcutaneous infusion of pump. You give desferrioxamine daily, about 5 days a week. So that is actually the difficult to manage. Nowadays, there is some of the drugs available, oral preparations like desferrioxamine, desferrol and deferricerox, Asunra and Calfor and so on and so forth. And these drugs can also be and alternate for desferrioxamine.
So there has a combination of blood transfusion, which basically essentially means that you just have to kind of flood the body with extra blood because the body is unable to produce the volume required. And the second is to manage the excess of iron that starts building up in the body because of the premature breakdown of the hemoglobin, which releases blood into our bloodstream. So does that mean that desferrol and that kind of medication you have to take daily for the rest of your life?
Yeah, that is actually required to be given at least 5 days a week. And,
wow.
And it is actually been to have a good weekend. Saturday, Sunday should be off from that point of view. Otherwise, ideally it should be given the whole week. And this is actually difficult to manage, but this is still gold standard of the treatment. But as I told you that there is some of the other drugs now available, oral preparation, which can be an alternate for this subcutaneous desferrioxamine.
Yes, quite right. So, Dr. Ayaz, from a layperson's perspective, well, first of all, how many transfusions on average does a thalassemic patient need? How often do they require a transfusion? Forgot the word.
That varies widely. In general, there's people who have thalassemia major and they basically require one transfusion every week or other week. So there's children we see that are requiring 2-3 transfusions every month. And when you multiply this by 12, that is 30 plus transfusions a year. If you have a 10-year-old child, he's already been transfused 300 units. The transfusion in thalassemia results in 3 major problems. Number one is, like Dr. Satti alluded to, is iron overload. All that iron accumulates in the glands, in pituitary, in pancreas, in heart and liver. You know, in our textbooks, they used to say that iron heart is a weak heart. Because the heart is full of iron, it doesn't pump well. So the other...
And philosophically too.
The other thing that happens is that in many parts of Pakistan, you're surprised to know there's only 4 or 5 hospitals in Pakistan that do the hepatitis C test screen, which is called the NAT test. In other places in remote areas, unfortunately.
Only 4.
And
so we're saying hepatitis B, but there's also hepatitis C, and there's also HIV, which is something that we really don't like to talk about. So if there are only 4 places in the whole country that are screening blood, that means that a lot of children are receiving blood that is not safe for them.
For hepatitis C. So they do screen with an antibody test for hepatitis B, C, and HIV. That is standard. But the test they should be doing, which is called the NAT test for hepatitis C, that is, so many times we'll see a child that comes from Pattuki or Multan or Islamabad that has thalassemia and has now developed hepatitis C to an already injured liver.
Oh my God.
And then the third problem is that more blood you give, the children develop antibodies and become sensitized to transfusion. So in transplant, we say more the transfusion, less the outcome of transplant. More transfusion, worse the outcome of transplant.
So Betty, we're saying that alloimmunization is almost an inevitable outcome of too many transfusions? Okay, so we have to take a break here, but I will ask you then about the alternatives to transfusions. Stay with us, we'll be back in one very quick minute. Welcome back to the coffee table. We're having such an important conversation about thalassemia with consultant hematologist Dr. M.Ayaz and Major General retired Dr. Tariq Mahmood Satti. So, Dr. Tariq, before the break, we were talking about how too many transfusions then lead to a whole host of other problems. And this is now where I'd like to kind of focus on both of your brilliant expertise with bone marrow transplants, and I know that you are a great pioneer of the haploidentical transplant. So tell me a little bit about what a haploidentical transplant means. What is that?
Yeah, actually the bone marrow transplant, as you know, is the procedure in which you take the stem cells of the donor. In Pakistan, it's basically the relatives, either mostly the sibling donors, brother or sister are the donors. But as you know that in the European countries, America and China and some of the other countries, they have the donor registry, so they can have two choices. One is sibling donor, and the second is the matched unrelated donor transplant program. But
so what we're basically doing, sorry to interrupt, we're basically doing with a transplant, a bone marrow transplant, is that we have to find a match to one's own bone marrow transplant. So then that can either be found through a family member, or it can be found through a donor who does have sort of a similar HLA profile as you.
Yeah, you're right. So, so what happens is that in a haplotransplant, what you do is that if there is no sibling donor or any donor which is fully matched with the patient, So you can take the siblings or the family members. Parents can be a donor if the child is small and the parents are less than, say, about 40 years of age. They can be a donor. Similarly, if the patient is slightly older and he have a kids, so they can be a donor.
Right.
And that is called the haplo transplant. Haplo is basically the half matched transplant in which the half antigens are matched. But the only is a special thing about this haplotransplant is that the patient should not have donor-specific antibodies in the blood. If they are there, then it's very difficult to go for the haplotransplant also.
Right.
So that should be ensured that the patient should not have donor-specific antibodies, the antigen which are missing in the patient. And the patient should not have those antibodies against those antigens which are present in the donor.
Because then that won't be a match. There'll be a lot of sort of attacking things happening there. So to kind of scale this back just a little bit, Dr. Ayaz, from what I understand, blood is made in bone marrow, it's made in cord blood, and it's made in peripheral blood stem cells. So what we're basically doing with the bone marrow transplant is that we are trying to flush out the bone marrow that isn't doing its job, that is sort of producing this genetically deficient, this mutated hemoglobin, and we're replacing it with healthy bone marrow. So it's kind of like changing the machinery, as it were.
You know, I give the analogy to my patients of the weeds in the field.
Yes.
So you have a field that has weeds in it and some wheat, and what you do is you burn the whole thing, and then you plant fresh seeds.
Yes.
And your hope is to get a healthy crop.
Yeah. Which is great, because then when we are then replacing the seeds and when we're replacing the defective bone marrow, what we're doing is kind of jump-starting the system to be able to produce healthy hemoglobin on its own. And then transfusions are not required if it's a successful transplant, or you just need them less. What's the outcome?
No, if the graft fully takes over, if your seeds are fully germinated, if they graft well, people become transfusion independent.
Excellent.
So we have patients that have never been transfused after the transplant. Sometimes you have patients that are partially dependent on transfusion for 6 months to a year, and then they become independent. But most of these people, they will become transfusion independent. And the key, if we were to communicate one thing through this whole program, is to do it early. The best outcomes of transplant are before 7 years of age. Unfortunately, a lot of people that come to us, they've never been told until the child is like 15 years old, 14 years old, when it's a very high-risk procedure, that they should have come earlier.
What are the risks of a bone marrow transplant? I'm glad that you brought that up, because I did want to ask.
There are three major things that can happen with a bone marrow transplant. If done in right hands, the procedure has a mortality, even in US and other countries, of less than 10%. There is the risk of graft versus host disease, which means the graft you give from one brother or sister to another may react against their body tissues, which can disturb their gut, their skin. And the third and major risk, especially, we have a very specialized, the places we trained in and the place we work in, we have a very specialized unit where the air is filtered, and we had all the precautions in place even before this COVID thing for infection. But eventually you have to send that patient to the village, the town they came from, where the hygiene and other practices may not be. I have a transplant patient who drinks well water. I ask her, what do you drink? She says, So the infection is the major complication in our setting.
Absolutely. You said if many patients who aren't diagnosed in time, or even if they are diagnosed, aren't able to get a transplant early enough, then one side sort of consequence of untreated thalassemia is that your spleen gets enlarged from all that overtime work that you mentioned the body has to put in. And I found it really interesting that the spleen, if the spleen is compromised, then you are considered an immunocompromised person, because the spleen's ability to filter your blood and fight infections is just really, really compromised by the disease.
That is true. Actually, one of the things that can help these children sometimes to overcome some of the transfusion need is removing their spleen. But obviously, that was put in place for a reason. God created spleen to filter bacteria and cells. And when that function is not there, these children, they stay at a lifelong risk of infection, and actually they have to be vaccinated against meningitis and pneumonia.
Yeah. No, that's actually, it adds another layer of challenges, doesn't it? Because you have a child that's already struggling with this genetic disorder, and then they are more vulnerable to other outside diseases, which like you said, like some kiddos show up with hepatitis that they got through a transfusion, or they're just more vulnerable to disease. And now with COVID in the air and everywhere around the world, it's doubly difficult to keep thalassemics safe and healthy. But one challenge that I'm wondering about, and maybe Dr. Tariq, you can tell me about this, is that I feel like when I was researching for this show, I found that there was a startling lack of data. Do we have a registry of thalassemics in the country? Do we have adequate data on how many people are suffering from the disease? Like the best thing I could find was a journal from a JPMA study from 1998, for example. And my second question is that how good are we on blood banks, for example, and transplant registries?
Yeah. Unfortunately, these both registries are not available in Pakistan. The figures which have been quoted as JPMC and all in the different work has been done by different, one of the society, that is the Thalassemia Society, has worked a lot, and General Suhaib is one of his pioneers. And the figures which we have at the moment is that round about 80,000 thalassemia patients, active patients, who are in the different centers going for blood transfusions are there in Pakistan.
Yes, which means those are only diagnosed who are receiving treatment.
And at the moment, and each year, around about 5,000 to 6,000 new cases of thalassemia major is pooling up in this pool. And the second thing, as you said, that the bone marrow transplant registry, again, unfortunately, there is no such system in which we have a bone marrow transplant registry, because the basic requirement of bone marrow transplant registry is that the volunteer donors should be there, and they should be done the DNA testing, that is HLA typing, to be done of those patients. And if they are volunteer for that, and then you have to donor registry to be made. Now we are working, and in Pakistan, the first time we have a Pakistan bone marrow transplant group, which is going to be now one of the society. And then this is the first goal, the target of this society is to start working on donor registry of bone marrow.
Yes. Do you feel like this is a combination of resources but also reluctance? Do you feel like there are cultural constraints where people feel nervous or hesitant about donating bone marrow? Or I know that we are all right for donating blood, but I have spoken to doctors who have told us that people don't donate as much blood as we think they do. Blood banks are always needing more blood.
Yeah, both the parts are there. The resources has also been required for donor registry, because whenever you make the donor registry, you do the HLA typing of the donor.
Yes.
And HLA typing is very costly affair, especially ideally it should be done high resolution technique. Even if you do by this serological technique, which we are doing at the moment, it still costs you round about, if you do the class 1 and class 2 antigen HLA typing, it costs you round about 20 to 25,000 rupees. So it's a costly affair.
Yes, and
so
per donor.
Yeah, to be a donor.
Yes.
The second thing is that if we can do the public awareness program, in which we can tell the people that as a donor, they have no risk, because the people think that they have to remove these bone marrow, say about 1 liter, 1.5 liter. Although in some of the cases you can do the bone marrow harvesting, but nowadays the technique is available in which you just collect the stem cell from the peripheral stem cell pheresis method, which is very safe. It is just like a blood transfusion, or once you are going something pheresis or something like that.
Oh, so that's great. That sounds quite manageable, actually. Like, no one's going to be like poking you with big needles or, chopping you up.
So actually, what requires is the public awareness program.
Yes.
Through media, through you can have booklets, you can have posters, and in the schools, teachers can give this to awareness program. So the most important out of this is, I think, awareness program, which is the key to the success of this whole donor registry and so on and so forth.
Doctor, when I was sort of reading up for this show, I found that cord blood is actually a wonderful source of stem cells and is also a very effective therapy for thalassemia. But I don't think that if there are any, there are very few cord blood banking facilities available here also. And I think that, do you think that that's something that we should be working towards as well?
I have experience with cord blood banking from US, where I trained and I practiced for about 15 years. Cord blood banking requires for example, New York has a cord bank that has 600,000 cords.
Wow.
And those cords, each of them has to be typed, like Dr. Journalist Satti said, 20 to 30,000 per cord. And so that's a very costly affair. You have to store them in liquid or vapor nitrogen at minus 180 degrees centigrade, where they can stay for years. So this is the most costly type of transplant. I think that it is not suitable. Technically there is no difficulty. We are capable of doing that in Pakistan, but I think it's not the most cost-effective type of therapy for this part of the world. We should focus on prevention. We should focus on early transplant. Just to give you a perspective, there's like 80,000 kids that need bone marrow transplant today. And the number of transplants being done in Pakistan in a year is less than 1,000.
Wow.
So if we stopped everything else and just did thalassemia transplant, the number of physicians that do bone marrow transplant in Pakistan is less than 20.
Wow, and so two of them are on this show right now.
So we are training new people. There's a very robust training program at the CMH in Rawalpindi. We have a training program. Khan has a training program, and IBD in Karachi. There's 4 or 5 centers that are working on increasing that capacity, because that is crucial. But I think if we can get a volunteer registry, and you have to understand in Pakistan, because we are not ethnically very diverse, there's only 4, 5, 6 type of people, unlike New York City where you have 200 countries in the same city. We don't need a very huge registry. If we could make a small registry, we could transplant people who do not have a match. And the most important thing is we could go exchange with other registries. 51 countries in the world have a registry, and they'll give you stem cells for free if you have a registry in your country, because it's on reciprocal basis. Right now, excellent. if we were to get cells from another country, right now it'll cost about $40,000 US.
Yeah. No, but that's really promising. And it's actually very promising to think that we don't even need a massive registry. We don't need millions of people donating. And I think that, well, thank you so much, both of you, for being on the show with me today and sharing your expertise and your insight with us. And the thing that I'm taking away from this is that thalassemia is still a problem in our country. One of the major causes of thalassemia is a lack of genetic screening and a lack of awareness of the importance of it. We are still marrying our cousins far too much, and so many people, and all the statistics show that up to 80% of couples who have thalassemic children were cousins. And they also didn't realize the importance of their being cousins and the effect that it was having on their families. So like Dr. Ayaz said, nobody can tell you who to marry. But it is certainly well within one's ken to go into any sort of situation where there will be children informed. And I think that it's important to perhaps normalize genetic screening across the board, because there are so many things that consanguinity does cause in us. And it's all right. It is what it is, but it's also very important to be aware. The second thing is the donor situation and a donor registry. I feel like if more of us step forward to donate our blood, our bone marrow, then perhaps something could be done about a registry. And these are just some things to think about. Thank you guys for watching this show. If you're watching this on YouTube, don't forget to like and subscribe, and we will see you next time on the coffee table. Bye.